So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to tonight's lung cancer living room. For those of you who don't know me, and I know that's not anybody in the room, but those of you who may be watching from your own living rooms, I'm Danielle Hicks. I am Chief Patient Officer here at GO2 for lung cancer, and I've been in this role for about 19 years now, always in the patient support and education and doing programs just like this, the Living Room, which has been around since 2009, where we really hope to bring to you live and in real time varying topics across the landscape of a lung cancer, whether you're at risk or lung cancer diagnosis itself. And tonight we're really, really, really excited to talk about survivorship. We spend a lot of time in this room talking about the more clinical aspects of this disease as it relates to your own diagnosis and treatment options. But tonight we're taking it a step further, and we're talking about what it's like to survive outside the diagnosis itself. Some of the challenges that come along with it, some of the things to think about, some of the thought-provoking things to think about. I'm thrilled. I'm thrilled about this conversation. We've gotten a lot of, there's been a lot of talk online leading up to this conversation, so I think it is something that a lot of folks are really looking forward to. Welcome again to those of you online. I just want to remind you that Michelle Zay is moderating the chat. She's in there, I'm sure, chatting it up with you right now. But if you have questions throughout, or if those of you in the room have questions throughout, or even comments that you'd like to make, please feel free to either type it in the chat, Michelle will get the question to us, or pick up your mic and ask it live in this room. As a reminder, we bring this to you for you. So please feel free to interrupt. If I don't happen to see you, give me a whistle, and I promise I'll look your way to get your questions answered. Before I introduce our speaker, I want to introduce what you guys might see behind me here. And it's this really beautiful quilt that says, "Amplify Humanity." This quilt, we're honored and humbled, really, truly, to have this quilt be here. It's been traveling since late May, early June. It started in Chicago at ASCO. You guys have heard me talk about ASCO, the American Society of Clinical Oncology, a big annual meeting that happens every year. And every year after that meeting, we have a living room where we're bringing you the latest and greatest information about the data that's being shared there. But that's where this quilt started. And my mom, Bonnie Adario, who's co-founder of GO2 for lung cancer, is featured on Pfizer's Amplify Humanity quilt. She was nominated and accepted, as I am sure comes to no surprise to anyone. Her picture is in that little white square on the top right corner, and then there's a beautiful book that comes along with this quilt to talk about all the people who were featured on here. It's patients, caregivers, and advocates alike. It was lovingly created by a man named, an artist named Joseph Thatcher, and it really weaves together stories and voices of patients, caregivers, and advocates, and each photo on here represents that strength, resilience, and the human connection. We are beyond proud to host this quilt tonight. I can't remember if I heard it came here from San Diego today. Michelle's nodding her head. Yeah, it came from San Diego. But it really speaks to the difference we can make when we all come together as a community. So if you didn't get a chance before the program, please don't hesitate afterwards to go and take a look and read the little feature about my mom. And those of you online, hopefully will be able to zoom in so you can get a better look. So with that, I want to get into the conversation, and I want to introduce Dr. Lidia Schapira. She's a Professor of Medicine and Oncology at Stanford University School of Medicine, Director of Cancer Survivorship at Stanford Comprehensive Cancer Center. And I had the absolute pleasure of seeing Dr. Schapira speak 2 conferences ago, I think now, at our Center of Excellence Summit, which I think was in Chicago that year. And I was sitting in the room texting Michelle saying, we have got to get Dr. Schapira to come in here. You know, her conversation was more geared and focused towards healthcare providers, but we have to kind of, you know, switch that around and let's have this conversation with the people living with lung cancer and their loved ones. So we could not be more thrilled to have you here with us tonight. Before we begin, because that's a really high-level, quick overview, you know, your title, but can you tell us a little bit about who you are and why this is an area of focus for you?
First of all, thank you all for hosting me tonight. It's a real pleasure, privilege to be here. So I am a medical oncologist. My clinical work is focused on breast cancer, not lung cancer. And I'm sort of classically trained to take care of patients, to think about new treatments, to participate in innovative clinical trials. But my real passion was always in understanding the lived experience of patients, caregivers, and families. So I have spent a lot of time with advocates, with communities that want to support patients and caregivers. I spent a lot of years as a volunteer with ASCO leading the patient information website because I always felt that people who had access to expert vetted good information were empowered to, you know, better advocate for themselves and perhaps find better treatments. And then I became involved in research to track, again, the experiences of young cancer survivors over time, and became very interested from the description to thinking about interventions, like how can we help people? You know, what can we do to help people feel more confident, to adopt a more useful, practical mindset, to get through these experiences, to advocate for themselves. So probably doesn't come as a surprise to you that with that kind of a background, I became very interested in how people live past the diagnosis of cancer. So if survivorship begins the day of diagnosis and remains for the balance of your life, it's like, how do you live like this? And that's what made me very excited to, when Stanford called and asked me to come in, you know, build a program to think about how we could bring different people together to build a community that is constantly thinking about this and innovating and also giving back.
Yeah, and I think it's interesting to think about, and we're going to get a little bit into the history of survivorship, because historically speaking, and really not all too long ago, it wasn't something people were thinking about, which is fascinating to me, and it was a miss, I think, for a long time, because a cancer diagnosis is a disruption. Right, it's a life disruption, and I think quite often we don't think about those disruptions and how they impact the lives of people living with just cancer in general. It doesn't even necessarily have to be you know, lung cancer. So let's start a little bit of history around the survivorship movement. Can you talk a little bit about that?
Yes, so, you know, again, what you point out is, I think, what has been a bit of a misconception and maybe has stopped us from advancing in this field, you know, for some time, and the idea that survival begins at a certain point after treatment or so on. Survival begins from the moment of diagnosis, at least that's, you know, better describes the lived experience of people. And the survivorship movement and science and discipline began about 40 years ago, when a young surgeon who himself was diagnosed with cancer wrote a beautiful essay that was published in a top medical journal describing the seasons of survival and describing the problems he had after cancer treatment. Life didn't just snap back to normal. Things didn't just look rosy. He had a lot of complications of medical therapy. And so this young surgeon, together with researchers and physicians, founded the sort of an advocacy group to represent survivors, coined the term survivors. And then from that point on, then that sort of gave a voice to people who had, you know, what we will call lived experience, who insisted that the research needed to go beyond the treatment and also look at dimensions of quality of life and the repercussions of the illness on family members, on caregivers. And with that, I think that the times also were coincided with us beginning to talk more sincerely and address more rigorously through our research, the quality of life dimensions, the impact of cancer therapies on many domains of life, the social life, physical life, spiritual life, psychological life. And so the survivorship science grew at the same time as the symptom management science grew. So with palliative treatments to mitigate symptoms, with survivorship science that was focused more on how people can live with and past the illness, with and beyond, I think is where we are now. The definition of survivor now is very inclusive, and it includes anybody living with cancer or living beyond cancer. We're not caught up in whether somebody's cured or not. That distinction does not seem to be as helpful as the idea that there are processes that begin at the time of diagnosis. I have a friend who is a phenomenal colleague as well, who was diagnosed at 32 with pancreas cancer, right after he got his PhD in neuroscience.
Wow.
And he has this incredible way. He's a 14-year survivor of pancreatic cancer, still living with this disease. And he basically says, from the moment you hear that you have cancer, the gorilla in the room is the fear.
Yeah.
You learn to go to sleep with this gorilla.
Yeah.
And the gorilla sometimes snores. It's loud. The fear, that destabilizing experience is there with you. And then you need to get past it. So for me, I think that's sort of part of the inspiration of thinking about how we can take some of those experiences, understand them through perspective taking, through compassion, through empathy, but very importantly, try to figure out how we can reach out and be useful and be helpful to people who've gone through that and are living with that.
Yeah, I agree. And I think especially now, not especially now, because I don't want to insinuate that it hasn't or shouldn't have always been important. But when I think about where we are today, when treating cancer in this era of sort of precision medicine.
Yes.
And people are living longer with, are being cured, I think it's an incredibly relevant time to further sort of kick this concept down the road around the importance of the conversation of survivorship.
Yeah, the conversation is focused on living and living well.
Yes.
However long you have. And a lot of people, I think, today with precision medicine and more treatments and more treatment options are living longer. But there's the uncertainty. You don't know when the treatment may stop working if you're living with disease, or you may live in fear that the cancer could relapse until you reach a point maybe many years later. But the question is, how do you live that time? And part of what I think I'm so passionate about is trying to help people to live well. Sometimes, we do our best, but we still can't foretell the future. And even with all of the precise elements we have that are getting better and better and better, there's still going to be some room for not knowing. So part of, I think, the challenge for all of us is how to learn to accept that there are some things we don't yet know or can't quite predict, and to live well.
Yeah, the gorilla might sleep more quietly, but the gorilla's still there,
yes,
right? Yeah,
correct.
And I think, stepping back and before we get into some of the more complexities, it really starts with something as basic as identity, right? And how people identify, and the fact that not everyone wants to be identified in the same way.
Absolutely. Some people reject even the label of survivor. They don't feel they've suffered enough to merit the term survivor. I've had many patients who've told me that because they didn't get chemotherapy, they can't identify with a survivor. And some who feel that that term just is inadequate and they want something that is more powerful, like thriver.
Yeah.
And that's fine. And some don't associate with any of these words. It's not about the label. The label has stuck because it's convenient and because we're trying to identify this, when we do research or when we set up programs. But we have to go past the label and just think again about community, about being inclusive, about, being with people who may tell their story in a very different way that does not include the term survivor. So I think perhaps the meta concept is the idea of creating a narrative about what that illness has done to life, to meaning, to goals, to relationships. And whatever it is we call it, I think what every person can do, a person who's been affected and a loved one, a caregiver, is to really try to think about how they want to shape that story, that narrative of illness.
It's really interesting because as we're talking about this identity space, it's dawning on me, right now, with the thousands of people I've met over the, last 19 or 20 years, there are people, and you touched on it, which is why I'm bringing it up, that don't want an identity at all. They don't, their choice and their right, in some cases, is not to even share the information with people, whether it be in a professional environment, or sometimes even in the beginning with their own families. And there's, I think, the fear there not only is around, I don't know what this diagnosis means or what my prognosis might look like, but also I don't want to be treated differently.
Yeah.
Right? Like I don't want someone all of a sudden to be extra nice to me because I've been labeled in some way.
So right. I mean, some people really don't want to disclose a diagnosis at work because they don't feel that it's anybody else's business to know. Some people don't want to disclose it socially because they don't want the sympathy looks. They don't want to be treated differently. And in my travels recently to listen to some of the European advocates, there's also a very strong movement there, is what they call the right to forget. They don't want to be labeled, perhaps, and there are still countries in Europe where it's difficult to get a loan, to get a mortgage, to get insurance after cancer. So that's where this idea, the right to forget, also comes, that, as you say, people can choose how to do this, but sometimes the people actually need to be given the space to be without being constantly reminded or drawn to this part of their life. And I think that's what makes this so interesting, so human. Talk about being human. This is about being human, about trying to think about how cancer, again, has sort of maybe changed, shaped, or impacted identity and life and meaning. And it's much more than just a label or needing to feel that you need to fit in what you think, other people's idea of a cancer survivor or a cancer patient is.
Yeah, and I think it's interesting because you pointed out every individual has the right and should consider and think about their own narrative that they want to put around it. And even within that narrative, wherever on that spectrum of comfortability from an identity standpoint you might live, to understand that it's okay to take days off. And just be like, today I'm just Danielle.
Yeah.
Yeah.
And, what I've learned from many of my patients who've been kind enough to share their insights with me is that many times people want spaces that are cancer-free, where they don't want to be associated with that part of their life, and that's perfectly fine.
And when we had talked previously, I think having these open conversations, particularly with those close to you, opens up and helps people to sort of understand how and where they the person diagnosed might need help from others and where they don't. But if we're just being quiet about it, can you talk a little bit about the importance of that?
Yeah, I think that in general, what we've learned, again, from the science side, and certainly my 30 years of clinical experience would say this is true, is that what doesn't help is to feel isolated, alone, or disconnected. That just intensifies the fear and the darkness, and what does help is to feel supported. And sometimes you need to be open and clear with loved ones and tell them how you wish to be supported, or create times perhaps when some things are spoken about or sometimes not. So I think that, I'm not sure if I'm answering your question correctly. If not, just ask me again.
Yeah.
But I think the most important thing is, again, to sort of to have some clarity over what it is that you think you need to feel calm, to feel that, that you are able to soothe yourself when you worry, to feel supported, to feel loved, and to feel accompanied. And I think there's a role for different people to play. I sincerely hope that if people are in treatment, for instance, that they would find that somebody on their clinical team is actually part of that support circle or network. And sometimes you need to ask for that or build those relationships. And it may not be everybody on the team, but as long as there's one. Same with friends, same with, people close to you. And I think that's where, the bit of the creativity needs to come in, but also to be clear about what it is you need and what it is you want and when you want it, the timing, as we said before.
Yeah, and I think a little bit later on in our conversation, we're going to talk about the clinical team and that role. And maybe, I'd like to poll the room and maybe people online about how many feel they're getting that from their clinical teams. I have my own sort of idea about what that might look like and a need for further education from a healthcare provider standpoint. But we're going to talk about that in a second.
I want you to teach me.
Yeah. So we talked a little bit, another thing you talked about where gaps in knowledge about what happens after cancer treatment starts, when it ends, or like anywhere, in the middle of that spectrum. And as people live longer, the impact it has on overall health. People are either on therapies for longer, as we see now, particularly with targeted therapies and immunotherapies, long-term side effects that sort of come along with that. And what you said to me is science is built around symptom management and survivorship.
Yeah. So the lung cancer community is catching up to the breast cancer community. We have kept our patients on maintenance therapies for a decade, for a very long time. And we have treated advanced or metastatic cancer for years and years and years, also with some oral therapies. And now the lung cancer community has more therapies that also are sort of given for longer periods of time and are helping to keep people well. In this, when we study the science of symptoms and symptom management, we often talk, and forgive me now for going for a moment on a didactic here. We talk about long-term effects, meaning the symptoms that start when you're getting a treatment but persist. And the classic example for anybody who's received a drug called paclitaxel is neuropathy. And there are other drugs like platinum drugs and taxane drugs that can cause neuropathy. That may start with a treatment, but it may persist. And it's possible that some form may never go away. So those are all the long-term effects that are with you, fatigue and so on. And then there are late effects, and those are the complications that may occur years or decades later. Typically, if you think about radiation, if you radiate a part of the body, the esophagus, the prostate, for instance, there can be some strictures that occur just, years or even decades after. Some drugs we give may hurt the heart many years later, so we have to worry and do something about that for surveillance and to keep people healthy. And now with immunotherapy that is so widely used and has been so helpful with lung cancer and other cancers, you can have toxicities that we never suspected before. can cause, inflammation of the bowel, can cause the thyroid gland to shut down, it can cause the pancreas to be inflamed and cause diabetes, and so on and so on. And it can happen many months or probably longer afterwards. So I think that's the science of symptom management and the science of survivorship is based on recognizing, treating, mitigating, and perhaps someday preventing some of these side effects to make the physical toll of being on cancer treatment easier to bear, so that people can remain active and do the things they love to do, and and be as physically healthy as possible while we are also attending to cancer. So that's the bit of the art and practice these days, which is also why I'm such an enthusiast of good communication, because if there are physical symptoms, there is a science that is now mature enough to help deal with them, to address that fatigue, to address that neuropathy, to address the aches and pains and the problems. So, there's a lot that we can do. I'm not saying that it's going to repair everything, but there's a lot we can do to improve the symptoms, both pharmacologically and non-pharmacologically, which brings us to behaviors and the mind.
Yeah, no, I agree. And I think, the statement you just made around, effectively, there's sort of the clinical aspect and the side effect aspect, right? And then there's the psychological sort of piece. And we've kind of jumped back and forth a little bit between the two. But you mentioned palliative care earlier. And again, I know the folks in the room have heard me talk about the importance of palliative care till I'm blue in the face. But there's people online who maybe this is their first time joining. Can you talk a little bit about what palliative care is, because I think it's still stigmatized and associated with hospice care.
Yeah.
And why it's important.
So I've been doing this long enough to tell you that there are problems with names. And some of my colleagues at a major cancer center in Texas even switched the name from palliative to supportive care for a while. And when they did, they found an uptick in referrals. There was less of a barrier to cross from the oncologist to refer, from the patients to accept the referral. But basically, it's the part of medicine, the discipline in medicine that basically studies the relief of suffering. And suffering can be psychological, emotional, or physical. And it can apply to anybody with any disease, distressing neuromuscular disease, cancer, heart disease, many things. But palliative medicine basically is meant to support patients and families. And they can be experts at treating very refractory symptoms like nausea. They can be experts at helping control shortness of breath through many interventions, again, pharmacologic and non-pharmacologic interventions. They're very good at communicating, at solving some problems within families, sometimes in bridging that communication between the specialist. In this particular case, it may be the cancer team and the patient and the family. So they can be integrated into plans of care. And we favor these days integrating palliative care if it's available, if it's necessary, early on when there are symptoms. Now, I'll say for my clan, my tribe, the oncologists, that we all practice some form of palliative care, and some of us are very comfortable doing entry-level palliative care. And at some point, we may need help. Yeah. So it depends very much on what the practice looks like. I've worked in places where the integration was, really very well constructed, and I've also been in places where there's more reticence to refer, or there may be less availability of palliative medicine. But I'm always enthusiastic about bringing all the people in who can help solve a problem.
Yeah. I love that, and when we get back to the clinical team, I have some thoughts on that too. But I think this points to, and I just want to make this point, and I don't think it's off topic. I think it's on topic. The importance of patients or people living with cancer, the importance of them to report out side effects, because quite often, even still, there's a fear, you know, in that person's mind associated with, well, if I report, you know, that this side effect is becoming unmanageable, we're going to take me off of a potentially life-saving treatment.
Yep. I think you're absolutely right, spot on.
Yeah.
There is sometimes a fear that reporting the symptom may trigger the doctor to think the disease is advanced or progressed, and therefore there needs to be a change in treatment, or that the dose may be modified, and therefore you may not get the full benefit. I mean, all of these things are, you know, circulating in people's minds, and we know it, but there has to be good reporting both ways. And sometimes you find that, you know, even there's sort of a holding back from your spouse or your partner or your family caregiver, because you don't want them to be the informant and then make that phone call to the nurse or the doctor, which could get you in trouble, and then your treatment may be delayed or your dose may be cut. So we know that that happens. I would say that's not helpful, and it's not helpful to be miserable alone. And if there is an important side effect, it could also indicate there's some organ toxicity, and this is not the right drug. So I'm all in favor of open communication, but I know it's hard.
Yeah, it is hard, and I've heard people, you know, talk to people who have maybe waited too long, whereas if, you know, they'd reported it early on, it could have been managed while staying on therapy, but then they let it go so long that, you know, yeah. So report your side effects to your healthcare providers.
Yeah, and I'll say this, that we depend on our patients to report those. There are some things that we just can't measure, and one of those examples is that those nerve changes from the drugs. I mean, there's no blood test that we can do. So we have to ask, and there's no great physical exam part. You know, there are some physical examination techniques that can be used, but they're not particularly reliable. Yeah. So we really need the person to inform us. Yeah. And if we don't, and if we give too much drug, and then that person can never walk again, or, you know, there's some terrible nerve damage, then everybody feels terrible afterwards. But we absolutely need people to inform. Yeah.
Agreed. We touched on this a little bit, but let's talk a little bit about, there's a lot we don't understand, right?
Yeah.
But there are some things we do.
Yeah.
Let's talk about what we do understand when it comes to survivorship. You know, fear of recurrence progression is, I think, what we talked about. We've talked about distressing symptoms and what we can do about it.
Yeah, I think if I may say just a few words about fear of recurrence. You know, fear of recurrence, if you are in remission, a fear of progression, if you have advanced disease. So it's the same sort of psychological construct, and it is grounded in a profoundly destabilizing experience, which was the catastrophe of getting cancer. So it's not something that, you know, that it's really grounded in something. And the question is what to do and what you can do, and when you may need professional help. So there's, you know, fear of recurrence. First thing we do is we sort of normalize it, and we say yes. You know, I think one of the things that makes it more difficult is to worry alone. So trying to have somebody who can help, and trying to sort of think a little bit about almost like a diagnosis of the fear. When the fear typically comes at 2 a.m., and it may come because you have a physical sensation that takes your mind to, oh, this could be, you know, the headache could be brain metastases, the indigestion could be liver metastases. There's usually, or somebody that you know got diagnosed, and that may trigger those fears, or an upcoming scan may trigger fears. So all of these are things that you probably all know very well. But the thing is to try to sort of talk to yourself or talk to your brain and say, yes, I am worried. You know, sort of verbalize that, and then try to see if you're worried because of something that has happened, and then try to see if you can have some clarity around it. When should I call about this? who should I call? How long should I wait? Do I need to solve this at 2 a.m.? You know, can I bring my body back to thinking about perhaps some things that could be wrong that are not brain metastases? Maybe I missed my caffeine today and I'm going through caffeine withdrawal. Maybe I've got a viral illness and that's causing my headache. So I think this idea of, you know, trying to, you know, pause, ground yourself, take maybe 60 seconds, maybe a few breaths, try to think through what's happening, and then try to come up maybe with a clear, you know, plan of action. But again, these things typically happen at 2 a.m., so I realize that that's not when any of us are at our best.
Calm and relaxed, yeah. And I guess when I think about that and having, again, had all these conversations, how would you guide someone who, you know, maybe forgot that they stubbed their toe this morning and now their toe hurts? And I'm exaggerating, right? But like, because I know people that are like, well, am I being a hypochondriac or is this a thing, you know?
I think that you can sort of adopt a way of thinking about it that is more practical and more useful for that. First thing you can do is sort of feel your feet on the ground. Just ground yourself. Take a few breaths, name a few objects, you know, maybe even distract yourself a little bit. Just, you know, it's almost like, you know, the cleansing approach to just ground yourself. Yeah. And then think about, you know, try to track what it is that happened. Try to get some perspective. If you are lucky and your team, your clinician has been clear about what to watch out for, you can then go back and say, oh, I was told not to worry about this until 3 days pass or 4 days pass, and bring yourself there. And then try to think of, you know, who you can talk to. Maybe you want to text a friend. Maybe you want to call the clinical nurse if you're really worried and need directions. But, you know, that's how you sort of get out of there. If you find that these kinds of fears recur and they come all the time and they're intense and you can't deal with them, that's when you need maybe a little bit of help. Sometimes joining a group and being with people who can, you know, validate and normalize this for you is enough. And sometimes you need to address maybe the underlying anxieties and get some mental health support. So it depends. Again, I think almost everybody experiences some part. But if it's something that is building, then that's the time sometimes to ask for help.
Yeah, and that points, you know, back to the importance of that conversation with the clinical team early on, because I know even from my own experience, sometimes, good night, I get out of bed in the morning and I'm like, how did I hurt myself while I was sleeping, right? I'm limping my way to the restroom. And you know, when I think about it in this context or in the context, you know, of someone who, you know, has gone through a cancer diagnosis and wakes up in the morning and now they've pulled something, you know, in their shoulder, how could they not think, goodness, could this be my cancer coming back? And so having those conversations with someone, to your earlier point, on your clinical team early on to know when to utilize some of these grounding sort of exercises and say, okay, if it's not gone in this amount of time, then maybe it's something to worry about, is incredibly important. Is there research mapped out for any of this type of information?
In terms of some of these symptoms?
Some of the symptoms and managing them and what that looks like from lived experience.
Yeah, there's lived experience, there's physiological research, like what contributes to certain sensations. There's a lot of research on the toxicity of certain drugs. So all of this is pretty much, all that is known is available in guidelines. There are lots of guidelines from ASCO, from the Consortium of Cancer Centers and CCN, from professional societies, from particular disease-oriented groups that basically spell out how to manage these things. There are guidelines, for instance, that have looked like at all the evidence and has rigorously looked at data from studies looking at what works for fatigue, what works for cancer-related fatigue. There's been a lot of literature. what works to deal with chemotherapy-induced peripheral neuropathy. So all of these symptoms that have been studied, for which there is now rigorous evidence, we have constructed guidelines that are available to clinicians to help direct patients to the appropriate resources and the appropriate therapies. So for instance, for fatigue, it appears that for people who are able to exercise, exercise seems to be the best drug. There have been a lot of trials of pharmacological agents. They don't work so well. So there's some knowledge that we have in terms of, foods to eat, foods to avoid, lifestyle issues. There are some wonderful techniques, for instance, for dealing with insomnia. There's a form of cognitive behavioral therapy that is specific to cancer patients who have difficulty sleeping. So there is a lot of science and there are a lot of interventions. And these are, clearly in guidelines at the moment. So perhaps if you can speak up and have a conversation with a clinical team and they can point you to a specialist or can access those guidelines and find, again, both the resources, the pharmacologic and behavioral interventions that can help, they can do you a big favor. We've got evidence, for instance, to suggest that there are certain cognitive behavioral therapies that work for fear of cancer recurrence. There was a randomized clinical trial that was published in the Journal of Clinical Oncology where all of the other progress in cancer is published. So there is a lot of work being done to create, digital tools, to create forms of therapy, to find drugs. Again, as I said earlier, I'm a breast cancer specialist, and let me tell you that, I get really happy if there's a new drug that can deal with menopausal symptoms because I've prescribed so much therapy to very young women who find some of these symptoms very hard to bear.
Yeah.
So anytime there's progress and there are rigorous studies in any of these domains, these get published and these get attention. And I'll tell you one more. One of the most exciting studies that was presented at ASCO last year, published in the New England Journal of Medicine, which again is a top journal, was an intervention of exercise. It took years, but they did a randomized trial of people with colon cancer who were at very high risk of recurrence. And they showed that an exercise program that was supervised by a trainer actually had a survival advantage. And the magnitude of that survival advantage was the same as many of the drugs that were presented at that same meeting for other diseases. So when you ask about science of survivorship, it also includes, again, non-pharmacologic interventions that may be transformative in terms of improving outcomes, improving how people feel, but also possibly extending their life.
I love that. And I mean, the power of exercise, I think, is fantastic for a lot of reasons, for your mental, state, for your physical state. I wonder, though, for people with lung cancer, like where that threshold of how much you need to exercise, because a lot of folks, their pulmonary function's compromised, and they've got all, the average age of someone is still around 70 at diagnosis. They might have comorbidities like arthritis or, other types of joint pain, vascular stuff. I mean, so is there a minimum?
You hit on a wonderful challenge for us.
Yeah.
And I think that what that speaks to for me, the way I listen to it, is we often don't have a good baseline for where people were when they were diagnosed or their baseline level of health. So of course, if you're older, if you bring comorbidities, it's going to be complicated. But again, it's not just the cancer, it's the comorbidities that are in attendance, which again makes me think that it's important to have shared care, to have not only a cancer specialist on the team, but somebody who's good maybe at rehabilitation, maybe physical rehabilitation, a primary care physician, maybe a gerontologist, maybe another specialist to deal with things. So if you give me a case that's really complicated, it's going to be hard for me to solve it, just using one way of thinking. And sometimes we need a multi-pronged, multi-specialty approach to dealing with these things. But again, the part of what the survivorship movement, if I may call it that, is about is, almost the idea of identifying problems as early as possible, not waiting for the symptoms and the disabilities to pile up, but to try to think about what we call prehabilitation, like prior to surgery, is there a way that we can make somebody stronger? Rehabilitation after surgery, are there ways that we can improve that muscle tone, that we can improve function so people don't get deconditioned? And all of that, I think, will help people to have a better outcome. And then the psychological part, right? Because sometimes we can identify these things and we can offer these resources and people may not want to access them, including mental health. I must say this, this part of my feeling is that, that particularly in the U.S., sometimes there's still a bit of a stigma associated with mental, psychological, emotional health.
And with lung cancer on top of it.
And with lung cancer, and with cancer. And so I would love to see everybody have access to this from the moment of diagnosis, but of course that's impossible. We just don't have enough, and also, it's not built into things. But just the idea that, you need to make an effort sometimes to try to find all of the pieces that you may need. And that's why finding support communities, building a community, having a community is so important, because important secrets are shared, right? Important health tips are shared. People may know of certain, local resources that may help with exercise, with meals, with transportation, with anything that's needed.
I think that community piece is so important, and we've got prior to this meeting, and I'm gonna give a couple of shout outs to GO2 and how we try to support in this way. The Tuesday prior to the Lung Cancer Living Room every month, Michelle moderates a Gathering Hope community social, and we talk about conversations that happen there, and it's really is that peer-to-peer conversation where this shared learning happens at every meeting, and it's such an important piece, I think, of this that people either don't know exists or can't find access to. So shameless plug for Gathering Hope, second Tuesday of every month, 11:30 a.m. Pacific time. But a second piece of that, and another program that we just started about a year and a half ago, which I think plays a big role in what we're talking about today, is called Mind Over Matter. And it's a 5-week program, 90 minutes once a week, where tips and tricks and tools are shared and taught on how to deal with some of these big feelings that come along with the diagnosis. Because I think, I think that's something that's often, I don't want to say dismissed, but maybe misunderstood or underrepresented, right?
Yeah, and there's some very simple things, I think, that can be taught and can be shared. And that is, as you're talking about the mind, the mindset that you can adopt. We talked about the story that you tell, and the, side by side from the way you tell the cancer story or your personal life story is the mindset that you adopt. And the mindset is sort of the way that you look at a problem, the way you look at the world, the filters that you place around what you pay attention to, what you choose to pay attention to, or what you don't.
Yeah.
And you can adjust that. You can adopt a mindset that is more useful. Not that it's better, but it may be more useful. And one of the ways that you can make it useful is to think about what it is that your body can handle. Yeah. What can you manage? What can you handle? If you think that your body can handle something, it may be a more useful way than if you catastrophize and you find yourself sort of in a story of a shipwreck where everything everything is going wrong, and you may actually feel that way, but that's not going to be so helpful as thinking that, you are capable, your body can manage certain things. They've been prescribed because somebody thinks that you're capable of handling that. And that may be a better way to organize things. And that's one of the things that support groups, friends, and therapy can help with.
Yeah, that's great. I think we have a question in the back. Here, just talk a little bit louder to the room.
Okay.
Oh, there we go.
Whoa. Can you tell me more exactly how to get in touch with tips, trips, and
and tools.
tools? I have a couple friends who have lung cancer, stage 4, and they are not willing to come here.
Yeah.
They're partially in denial. One woman figures she's going to finish all the business she has and be the queen.
Yeah.
Because,
Yeah, Pat, we can absolutely point you in the right direction of either the Mind Over Matter program, Gathering Hope, where it's not required that you be, it's all virtual, but it's not required that you be on camera. If somebody wants to just come sit and listen and see if it's something for them, that they want to engage in, they can absolutely do that. So yeah, we can definitely point you in the right direction of that. One of the things we haven't talked about, and this is really fascinating to me because last month our lung cancer living room was really talking about young lung cancer. So lung cancer in people diagnosed under the age of 40. We know that particularly in women in this demographic, it's on the rise. And we talked about some of the unique sets of challenges that come along with that diagnosis, career disruptions, family planning disruptions, fertility preservation, all of these things that are sort of wrapped up in a, 30 or 40 something being diagnosed with lung cancer. And one of the things we talked about there was relationship dysfunction, which doesn't just mean like with your partner or with your loved one, but with your friends, with your coworkers and stuff like that. And so I think a lot of what we're talking about today, particularly as it relates to mental health conversations, creating the narrative, are important for those types of relationships as well.
Yeah, I think it's very difficult to be diagnosed when you're very young. What we know and what we hear from people in that age group is it's not supposed to be this way.
Yeah.
And I don't want to sit in a support group with people who are my mother or my grandmother's generation. So it's difficult. It's very difficult to think about peers who may be having children or getting promoted or finishing a degree when you can't. It's very difficult. It's not supposed to be that way.
Yeah.
And so I think that's sort of where you start with the whole issue of constructing a story that can help these young survivors to see what's right ahead of them. It's not helpful to them to think about long-term future. It's much more helpful, I think, to begin with the short term. So if you're a skier, you'll understand that you want to see somebody who's 3 turns ahead of you, so that you can follow their path, right? You don't, thinking about somebody who's accomplished something many years later, it may not be as helpful as, having some ideas that you're going to run a race or you're going to take a trip when you finish your chemo, or just something that's more proximal. And you have to, in some way, find a way of accepting what others are doing who don't have cancer. But it's very difficult to just wrap your head around this.
And I think that's true for people who maybe skew a little older at diagnosis, right? Because it's still a life disruption. I have vacation plans. I have grandchildren that I want to see get past XYZ milestones. I have family vacations.
Or the argument that it's not fair. I've worked all my life. I was looking forward to retirement and doing all these things and not end here. So that the unfairness narrative, I think, applies to everybody. And it applies to lung cancer, probably also because of the cultural stigma associated with lung cancer, but it can apply to any other major life-threatening, destabilizing illness. There are other illnesses other than cancer. We are, focused on one.
Right.
And again, I think lung cancer is one that in the old days also had a lot of stigma associated to it. Fortunately, I think we're coming out of that, but it may persist.
Yeah. I'm being mindful of time, but I really want to circle back to this provider thing that I've been sort of hinting at.
Yeah, go for it.
So not everybody has access to Stanford, where we know there's a true multidisciplinary approach to care and all of these resources, palliative care and otherwise, associated with, and these referrals and these things happen. We also know that 80% of the population is seen in the community setting, sometimes, quite often, not sometimes, quite often in more rural areas, where access to this type of information and support is not at the ready, maybe is not top of mind at a general oncologist who's just treating whatever walks in the door. So because of that sort of fragmentation within our healthcare system, how would you advise or guide someone towards this type of support?
It's a really complex question.
Yeah.
Anecdotally, I just came back from a congress in Tunisia where African nations sent delegates as they're trying to build a system for expanding their capacity to deal with cancer, which they are not able to do right now. So I'm very much aware of the global differences, of the regional differences, of differences in access, totally top of mind. My own perhaps contribution to that is, again, to contribute through posting things online that are free of charge. So currently, I think the American Cancer Society and other groups are really working on having expert-vetted information about disease and treatment so that can be accessed for people who want to learn more about their disease. I think there are many organizations nationwide, including yours, that provide support forums that people can access, not pay for in their, and join. I've certainly participated in many of these through many organizations. So there are many philanthropic and nonprofit and advocacy groups that offer support. So I think accessing support, accessing information online is good. Instead of going to ChatGPT as a doctor, I tell my patients, I'm your ChatGPT. Come to me first, ask me before you ask the bot. But you're absolutely right. People sometimes may not know how to distinguish things they see online. They may not be able to distinguish what's sort of quality advice from what's just, chat that is anecdotal and may not be helpful to somebody else. So again, I think that having the idea is to try to form a strong community of support. I think community really is incredibly important. Friends, people who are there to accompany you if you're having a bad day, I think that's helpful. Try to find somebody who's able in your own group to access the literature and sort of make sure that, there is some vetting of the advice. And in terms of resources, I think, again, community-based, organization-based, so outside of perhaps where you're actually getting treated, there may be other resources to connect to that are, rigorous and really deliver.
Yeah, I think that those are all excellent points. And I know, when we're out in the community talking to providers, particularly in more rural settings, we are consistently reminding them and people watching programs like this that we see ourselves as extensions of your healthcare team. Although we can't help you clinically, we can help you with questions to ask your doctor based on wherever you are in this experience, whether it's the at-risk sort of space whether it's at diagnosis or as you continue to live through the diagnosis. And that includes, helping find local resources wherever you are in the country.
And to return to your first question, in the arc of my career, my job now, I think, is to train the clinical teams to better respond to their patients, to help their patients to talk frankly and honestly and openly about what really worries them, to listen, to listen empathically, and then to try to connect them to resources to help. And I think that, thinking about all of that communication, all the sauces that go into that, all of the influences that go into that, it's not always perfect, but if we can do better there, we may help people also feel better accompanied, to get better resources, to get referrals early, to manage some of the symptoms, whether they're physical, emotional, spiritual, social, whatever they are.
Yeah, no, I love that. And I think, one of our main focuses with all of our programmatic efforts is to empower patients, right? So I love, how it works with what you're saying about your role in educating other providers around this messaging and this concept. So that's sort of the top down.
Yeah.
And then, not that patients are at the bottom, but the bottom up is, people who activate around their diagnosis become empowered, or then having those, I think it always surprises patients when they're like, hey, thank you for the conversation. My healthcare provider learned something today, right? And that in and of itself is very empowering. And it helps the next person to walk through that provider's door, right? So I think that, meeting somewhere in the middle, patients, like I said, who have activated around their diagnosis are not only helping themselves, but they're helping the people who are diagnosed in the future.
And they provide the inspiration for research.
Yes.
For ways of doing it better.
Yeah. Yeah. And I think that's an important point, too, because not all clinical trials and studies, and these folks all hear me preach about the importance of those, but not all of those are drug-based studies. There are other types of trials and studies and registries that you can join. Give your own patient-reported outcomes based on a vast array of experiential, sort of things that may or may not have happened that ultimately benefit the science community.
And the science of symptom management and survivorship care started by building these questionnaires onto the drug trials. So it's not either or, sometimes it's and. So yes, we want to know how this new drug works and whether or not it extends the, progression-free survival or overall survival for people with stage X lung cancer. But we also want to know how it impacts their functioning. So interestingly enough, some of these studies that address quality of life issues are published separately from the initial drug trial, and often are published 1 or 2 years later in less important journals. It would be nice if we can bring these communities together, but that is the state of things. But at least we have that science, and I think we need to be more active, sort of demanding that this kind of information be collected alongside,
in tandem,
published, and be used also for counseling patients.
You are preaching to the choir with me because I firmly believe that these types of studies should be happening in tandem so that we can get the lived experience in the moment as these things are happening and use those. I'm just repeating what you just said, but yes, I believe that wholeheartedly. Okay, we are going to, it is Lung Cancer Awareness Month, as everybody knows. And we are going to shine a light tonight for Lung Cancer Awareness Month prior to my little housekeeping and close. But before we do, Dr. Schapira, what do you most hope people take away from our conversation tonight?
That there is a community, that we can all work together to hopefully improve outcomes, however you want to measure them, both in terms of life and also quality of life dimensions. That I think sometimes we have no control over the ultimate outcome, but we have control over the stories we tell We have control over the narratives, and we have control over how we choose to look at things, the filters we draw around our attention. And so those are the things that we can all do in whatever roles we are, patient, caregiver, clinician, to really help mitigate that suffering and make the experience as good as it can be.
Yeah, I agree. So thank you so much for this conversation.
Thank you for inviting me.
Yeah, of course. Like I said, the first time I saw you, I was like, this is amazing. I love the conversation so much, and I think it's quite often, it's just not talked about enough. And I think a lot of people get lost and don't know how to find a way into these types of conversations. So I really, really appreciate it. For Shine a Light, so for those of you who don't know what Shine a Light is, it is the largest community-based, I guess, lung cancer awareness event that happens globally. It's called Shine a Light. It's hosted by healthcare facilities and community partners so that we can raise awareness and honor local lung cancer community in their own way. Whether it's an educational table, an in-person event, these folks are hosting, and it's free for attendees to come. Currently, this month, we have over 270 Shine a Light events happening across all 50 states, including DC, and 3 separate countries. So a huge shout out and thank you to Ireland, Canada, and Lung Foundation Australia. This month, we're going to host our own very Shine a Light. And this program is run by Katie Morello, who works on the events team and has done extraordinary work in ensuring that all 50 states, in some states, multiple locations are participating in this, and obviously done yeoman's work to get folks outside of the country participating in this during Lung Cancer Awareness Month. To generate that sense of community importance and that nobody, is fighting alone with lung cancer. So the ask, and I'm reading this because Katie Morello, who could not be here tonight, wrote this for me, and I'm sure she's going to go back and watch and make sure I touched on every point that she's making. But we're going to ask that Michelle just dim the lights for just a second. We're going to invite all people living with lung cancer and their loved ones to shine a light. It doesn't matter if you're a caregiver, a loved one, or anyone impacted by the disease. And as we shine our lights, we want to celebrate all those who are surviving and thriving, or however you identify. And remember, honestly, those that we have lost, and honor everyone who's been impacted by this disease. Our lights are a symbol of the progress, support, and hope that is created when we come together. So, yeah, thanks everybody for shining a light. Everybody, if you're not done, feel free to leave your lights on. Okay, now to housekeeping and then dessert. And I'm going to have an enchilada because I haven't had one yet. Up next, as you guys know, Gathering Hope, December 9th, 11:30 a.m. Pacific. Our Living Room, December 16th, is going to be our annual holiday celebration and really reflecting on 2025, all the successes, all the advancements, all the amazing things that have happened and the amazing things to come. So please join us for that, that celebration on the 16th. I want to say another huge thank you to Dr. Schapira for coming out and talking with us tonight. All of you who have joined us at home this evening live from your own living rooms, and those who will come back and join post-live, Penn Media for all the efforts in setting up the studio every month, Onyx and Ash, the entire GO2 team, Michelle for moderating, and just everyone. It would not be appropriate for me to not thank the very long list of people who, without their support, we couldn't bring this. So Abbvie, Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Novartis, Novocure, Regeneron, Revolution Medicine, Summit Therapeutics, and Takeda Oncology. And this year in particular, I would be especially remiss in not thanking all of those who have, and I don't know why I'm getting emotional, who have so generously given to the Bonnie Dario Legacy Fund. We really kicked butt this year, and the support, the overflowing support that has come in the door, particularly in the last few weeks, has been very heartwarming and overwhelming. And you know, all of the money that is being given to her legacy fund is restricted to programs like this. So it's to help continue to support this mission-based work and educating and supporting our patient and caregiver community. It's going back out the door to support our healthcare delivery team and their efforts to continue to support, particularly those in the community setting, and encourage them and celebrate those who have and or are developing comprehensive lung cancer specific programs. And then, of course, the research that we do, particularly through Alchemy, the Dario Lung Cancer Medical Institute. So all of that funding comes right back in the door so that we can keep doing this. So huge thank you to all who have given to that fund. And with that, now we're really going to go have dessert. So thanks, everybody. I'll see you next month.
So I'll be brave if you're brave. I'll be brave, but only if